Hi, my name is Annie Heenan. I'm a fourth-year MedPeds resident at UNMC, and today I'm going to be presenting a case of complicated MSSA bacteremia following an influenza vaccination site infection. This was a case that we saw on our UNMC wards teams last fall, and I put this together with the help of Lauren Keim, who's one of our second-year IM residents. The patient is a 75-year-old male, and he presented to his local emergency room with altered mental status consisting of confusion and agitation and expressive aphasia. He was found to have an intraaxial hematoma of his left parietal lobe with localized mass effect and was transferred to UNMC for a higher level of care. Prior to his admission, he'd been having 2 weeks of intermittent fevers, which were treated with a course of oral doxycycline by his primary care doctor for an upper respiratory infection, but he had no improvement with this oral antibiotic course. A week prior to admission, he had a ground level fall, but was back at his baseline mental status after that fall. With the exception of some pain in his rib fractures, he was otherwise asymptomatic. On his initial exam, he had a Glasgow Coma score of 12. He had a benign cardiac, pulmonary, and abdominal exam. In his neuro exam, he had pupils that were equally reactive to light and accommodation. His extraocular muscles were intact, but he was confused with expressive aphasia. He was unable to have his cranial nerves assessed because of his aphasia. He was moving all 4 extremities spontaneously and localized to pain in all extremities and was normal reflexive. On presentation, he was febrile with a temperature of 39.6. He was mildly hypertensive and tachycardic, as well as tachypnic, and was saturating well in room air. His initial labs were significant for a white blood cell count of 18, a troponin of 0.6, mildly elevated liver enzymes, NT bili, as well as an elevated procalcitonin. Here I have pictured his initial head CT, which showed that left parietal lobe hemorrhagic stroke. His clinical course started with non-operative hemorrhagic stroke management consisting of Keppra for seizure prophylaxis as well as strict blood pressure control. It was deemed that he had a type 2 NSTEMI after having a normal EKG and no wall motion abnormalities on his echocardiogram. His blood cultures quickly grew methicillin-sensitive Staphylococcus aureus, and his mental status improved and was nearly back to baseline after 3 days of antibiotics. He was found to have a 1 by 3 centimeter area of fluctuance, erythema, and tenderness over his deltoid muscle. This was the site of his influenza vaccine that was administered 4 weeks prior to admission. The fluid collected from this IND grew MSSA. He had persistent bacteremia, which prompted further investigation with concern that source control had not been obtained. An MRI of his spine, due to mild pain, showed T10 and 12 osteomyelitis with an epidural abscess that required drainage. These cultures were positive for MSSA. He also had an MRI of his left wrist that was performed due to some mild stiffness, which showed an ulnar joint infusion, but these cultures did not grow anything. A TEE was done for a new murmur and his persistent bacteremia, which showed a 1 by 4 by 0.4 centimeter vegetation on his mitral valve. I have some clinical images here. The top left one is of his deltoid. This was post-IND and was the site of his influenza vaccine. In the top right, we have an image of his echo, which demonstrates endocarditis on his mitral valve. And the bottom picture is an MRI of his spine, which demonstrates his epidural abscess and osteomyelitis. The patient was treated with an extended course of cefazolin and on subsequent admissions required long-term antifungal therapy additionally after he had recurrent brain abscesses that required evacuation and cultures that were positive for yeast growth. And he eventually did require a mitral valve replacement. Prior to the initial presentation, the patient had a medical history of hyperlipidemia, no history of IV drug use or any prosthetics in his body that would predispose him for bacteremia. This patient's bacteremia with seeding to his spine, wrist, and mitral valve is thought to be secondary to skin infection associated with his influenza vaccine. His initial presentation with a hemorrhagic stroke was attributed to septic embolization. While cellulitis is the most common infectious event after administration of vaccines, case reports have identified bacteremia, osteomyelitis, meningitis, and neck fash secondary to parental injections. The majority of these infections are due to MSSA, but there have been case reports of transmission of infectious agents such as MRSA and Mycobacterium, and even case series where multiple infections have been linked to a single vaccine administered. There are varying standards internationally for skin disinfection guidelines prior to injections, but overall, they're not very stringent. Current WHO recommendations do not require cleaning the injection site unless the skin is visibly soiled or dirty. OSHA guidelines do not require gloves to be worn during vaccine administration, and CDC guidelines recommend standard hand hygiene, but don't have standards for patient skin sterilization. Small studies have shown varying effectiveness in disinfection rates using isopropyl alcohol and other sterilization techniques. I think there needs to be further research regarding sterilization techniques and associated patient outcomes because they can be quite severe, as seen in this case. Standardization of sterilization techniques could potentially decrease the infectious complications of vaccine administration. This case also highlights the need to recognize that intermittent fevers following vaccine administration could indicate bacteremia. The patient's delay to appropriate medical therapy led to seeding in multiple locations as well as a hemorrhagic stroke. While this presentation is rare, early recognition may have prevented the severity of his presentation. Just to clarify, I am certainly not an anti-vaxxer, and the pediatrician part of me was very hesitant to write up any potential bad outcomes of a vaccine, but I thought it was such a good learning case for me that I wanted to share this case. And for me, it highlighted a couple other items as well, too. One is how subtle some of the symptoms of seeding could be. This patient had very mild back pain and stiffness, and it took ortho quite a while to even convince us that it was worth imaging. And additionally, while vaccine administration is a very common part of our practice, I think we can sometimes be lackadaisical about counseling on the risks and benefits, and it's important, especially when we see outcomes like this, that we are making sure that patients are making an informed decision. Here are my references, and open to any questions. Thank you.